Good day. I'm Ann Casson, and I'm one of the fertility nurse specialists at Memorial Sloan Kettering Cancer Center in New York City. We provide fertility and family building consults to all of our patients, as well as serve as a liaison between the medical team and the reproductive endocrinologist. I'm honored to have this opportunity to discuss fertility and fertility preservation in the setting of Fanconi anemia. I hope this talk offers some general guidelines for you, but at the onset, I want to disclose that fertility is an understudied aspect of Fanconi anemia and deserves further attention in the future. We will review the biology and impact of Fanconi anemia on fertility, options for fertility preservation, and we will review family building options, including biological and third-party family building. And I will end by leaving a list of resources for you. Let's start with a little female reproductive biology. Female reproductive structures include the uterus, which will carry a pregnancy, and ovaries, which house our eggs. With females, it's important to understand the effect of age on ovarian reserve or egg supply. Unlike males who are making new sperm throughout their life, females are born with all of the eggs they will have, and typically it's somewhere around 1 million eggs. Over the next 5 decades, these eggs are slowly dying off, and when we reach about 1,000 eggs, we will stop getting our periods and go into menopause. Over these same 5 decades, as the eggs age, there comes a decrease in the quality of eggs and subsequently a decrease in fertility, making it harder to get pregnant as we age. It is also known that women with Fanconi anemia are at risk for premature ovarian failure or premature menopause. Although we don't know exactly what this curve looks like, we know that most women with Fanconi anemia will have premature ovarian failure by their early 30s. So what are the effects of Fanconi anemia on fertility? As we just saw, that we are at risk for women with Fanconi anemia are at risk for premature infertility and menopause. Additionally, some women with Fanconi anemia may have trouble carrying a pregnancy to term because of a small pelvic girth and should be followed by a maternal fetal specialist when pregnant. What are the options for fertility preservation for prepubertal females? Prepubertal females who are not undergoing gonadic toxic therapy or a stem cell transplant do not need to have any intervention. Once they hit puberty, because of the risk of premature ovarian failure, at some point you might consider having an ovarian reserve assessment done. I will go into what an ovarian reserve assessment is later in the talk. Prepubertal females who are undergoing a stem cell transplant or gonadic toxic therapy might consider ovarian tissue cryopreservation. Ovarian tissue cryopreservation is the only fertility preservation option available for prepubertal females, as without the hormones associated with puberty, mature eggs cannot be collected for freezing. Ovarian tissue cryopreservation is done in hopes of freezing the primordial follicles in the ovary for future use. Ovarian tissue is no longer considered experimental, and almost all of the successes that have been reported have been by women who froze their tissue post-puberty. So what is ovarian tissue cryopreservation? As I said, this is the only option for prepubertal females, but it's also an option for females who cannot delay treatment to freeze eggs. And you should be and must be at high risk for ovarian failure from your treatment to be considering ovarian tissue cryopreservation. It's no longer considered experimental, And in order to freeze ovarian tissue, you must have the removal of one ovary, or they do ovarian cortical biopsies. However, most centers do remove an ovary in order to freeze tissue. Once the ovary is removed, that it's frozen in wedges that can be later reimplanted. So in the future, when the female is ready to build a family, a piece of that tissue can be reattached to the remaining ovary. It's hoped that that tissue contains follicles that will now undergo maturation and either be released during ovulation to allow conception to happen naturally, or eggs can be stimulated to be collected for IVF, where the embryos are created outside of the body. As of 2022, there have been approximately 200 live births from ovarian tissue. 50% of these births have been conceived naturally, and the other 50% have been conceived by IVF. The centers that have tried using ovarian tissue will quote success rates of 23 to 36%. Some of the risk with ovarian tissue cryopreservation is if that ovary contains disease, there is a risk of reinducing the cancer cells back into the body at a later date. So you would want to make sure you're in remission when the ovarian tissue is procured. What are the options for fertility preservation for females who have reached puberty? So post-puberty, again, with no gonadotoxic treatment needed, again, you might consider an ovarian reserve assessment, and then based on the results, consider egg freezing. Post-puberty and gonadotoxic treatment needed or stem cell transplant needed, you might consider egg freezing. Egg freezing is the gold standard for fertility preservation, but you must be post-pubertal to have your eggs collected and frozen. And as a side note, although stem cell transplant regimen typically carries the highest risk for infertility, women with Fanconi anemia have been reported to carry pregnancies after a transplant, owing this to the lower cytoreduction needed for FA women. And we're going to review the process of egg freezing shortly. Before we review the process of egg freezing, we have to go back to a little female reproductive biology. This is a cross-section of an ovary where all of our eggs are housed. When we're born, the million eggs that we're born with are all up here near the outer cortex of the ovary in this inactive state. And these are also called primordial follicles. Once we hit puberty, because now we have all the hormones circulating that comes with puberty, what happens is each month, not just one egg, but a group of eggs in both ovaries leave this resting state and start to grow and develop. Of the group that's growing and developing, only one egg, for lack of a better word, becomes the dominant one and will reach full maturity. That's the one that will be released during ovulation, and if fertilized by sperm, will lead to a pregnancy. The other eggs that left that resting state and are growing with it are going to die off. Women who are seen for either an ovarian reserve assessment or for egg collection, the first thing that is done is an assessment of the ovaries to see, do they see a lot of eggs in your ovaries? The younger you are, the more eggs they should see. The closer to 1 million eggs you are, the more eggs they should see. How this assessment is done is there's blood work looking at your hormone levels, and then there's a transvaginal ultrasound that will look at the ovaries. This is your ovary. They can't see these eggs in the resting state. They're too tiny. They can only see the eggs that are growing and developing that month, and they can see the one that will be released during ovulation. And they are going to count them, and that's what these black holes represent, growing follicles. The younger you are, the more growing follicles they see. And this is your ovarian reserve assessment that we talked about earlier. There are norms for every age depending on how old you are. And so if you are 20 and having a ovarian reserve assessment, they have an idea of how many of these follicles they should be seeing on the sonogram and can give you an idea of your risk for premature ovarian failure. This is also the first step in egg collection for women who are going to freeze their eggs before they start therapy. What happens from this point on is that if you are going to freeze your eggs, these in fact are the eggs that will be collected and frozen, the eggs that were going to die off this month. The reproductive endocrinologist is going to teach you how to give yourself an injection to support the growth of these follicles so that not just one reaches full maturity, but all of these other ones that are growing will reach full maturity too. It takes about 10 to 12 nights of shots, and then after 10 to 12 nights, and it takes monitoring throughout this period, you will give yourself one last injection, and they will tell you to come in for collection. Collection is done under anesthesia. It takes about 15 minutes, and the collection is more a procedure than it's not a surgery. They're collected transvaginally with an ultrasound wand, and this time at the end of the ultrasound wand is the little needle that goes through the vaginal wall and collects the eggs. You wake up 15 minutes later and they tell you how many eggs they've collected, and those mature eggs will be frozen for future use. Insurance may or may not cover egg freezing. There's a better likelihood of it being covered if it's before a stem cell transplant, but many still do not have coverage. Without coverage, egg freezing can cost about somewhere between $10,000 and $15,000 a year, depending on your geographic location. And then there will be annual storage costs of somewhere between $1,000 and somewhere around $1,000. Alternative family building options include third-party with eggs or embryo, third-party eggs or embryo, and also surrogacy with a gestational carrier if you find that you're unable to carry a pregnancy. And then adoption is also an option, although you need to be cancer-free for at least a few years. This few years is not well defined. It varies depending on what agency you're going through, and you will typically need a physician letter stating you're in good health. Third-party donor options, although it's very successful for many people, it is expensive. Donor eggs or donor embryo can be anywhere between $30,000 and $35,000. And surrogacy using a gestational carrier can be somewhere between $100,000 and $150,000. The reason why this is so much is that the gestational carrier needs to be screened. A lot of their costs need to be paid for. You need attorneys to make sure that everything is done properly. And then some resources for family building would include Family Building Net offers counselors and offers stress management techniques helping you navigate the fertility treatment. Some of the financial resources are Cancer Finances, Hope for Young Adults with Cancer, the Livestrong Foundation. These all offer either financial grants or help with family building. Additional help for family building include the SAM Fund, Fertility Within Reach. Patient Advocate Foundation can help serve as liaisons between the patient and insurance to help with financial matters. And then lastly, ReproTech can offer cost-effective storage for long-term embryo or egg freezing and sperm freezing. And Team Maggie also provides financial assistance for sperm and embryo freezing. Thank you very much. I hope that this was helpful for you. And in conclusion, again, the FA and fertility needs to be studied further in the future.